Dear Chairman, ladies and gentlemen, thank you very much for the opportunity today to present our data here. As you said, on the early MARS treatment in post-hepatectomy liver failure. And it's preliminary data of a phase 1 study. So just very briefly to the background you're all aware of. Post-hepatectomy liver failure is still a major problem. The incidence varies largely according to the literature and is seen still as the main reason behind postoperative mortality after major liver resection. But still the complex pathophysiology of PLF is poorly understood, and the treatment options, as you're all aware of, are very limited. With this background, we ask ourselves if there might be a place for artificial liver support and if there is any evidence. If we have a look to the literature, we found that very few studies have been published. These studies contain only of single-center experience with artificial liver support exclusively for the post-hepatectomy liver failure situation. And these reports always contain just a few number of patients, present heterogeneous treatment groups, and all suffer from a lack of a standardized treatment protocol. So what we did actually, based on our own retrospective experience together with the Barcelona experience, that we designed a study protocol, and we asked us the following research questions. If, in our case, the MARS system, the molecular absorbent recirculating system, which is available in our hospital, if there is a chance for this artificial liver support to be applied in the early phase of PLFF, and if MARS is safe and feasible when it is used according to a predefined standardized treatment protocol for treatment of post-hepatectomy liver failure. Excuse me. So we designed the following study protocol. As I told, it's a phase 1 safety and feasibility study. We are aiming for 10 consecutive patients being subjected to extended liver resection. As inclusion criteria, we choose, in our opinion, the most easy one, the 50-50 criteria, as it predicts mortality with more than 50% at POD5. The patient or a relative gave informed consent, and as contraindication or exclusion criteria, we just choose any contraindication for liver dialysis, as, for instance, ongoing bleeding. So, how we include our patients. When the patient was operated with a major hepatectomy, the patients routinely is transferred to our intermediate care unit. And there the patient, of course, is followed the first postoperative days. And on POD3, postoperative day 3, we identified patients at risk for fulfilling the 50-50 criteria. If this was the case, we started to check these patients for complications. If we thought it might be useful, with a CT ultrasound to exclude infections, fluid collections, and bile leakage. And those complications were tried to rule out on POD 3 and 4 prior to onset of the MARS treatment. And then on POD 5, if the patient was fulfilling the 50-50 criteria, we started the MARS treatment. Actually, unfortunately, according to practical problems and problems with the resources and the ICU, we had to adjust a little bit. We were aiming for a start at POD5, but due to practical reasons, we had to adjust this, and we're starting MARS between POD5 and 7 in the end. If I might show you the preliminary results. Now, I include 8 patients. Actually, we have treated now 10 patients, but it hasn't gone 90 days since then. So I just try to, or like to present you the first 8 patients. As you can see, a typical Nordic patient collection here. The people are, or the patients are between 60 and 80 years old, equal between female and male. And as you can see, it took us a while until we could include those 8 patients. It was more than 1.5 years to see enough post-hepatectomy liver failures, which is actually one of the problems in this study. And all of the patients were subjected to extended surgery, mostly primary cholangio or hepatocellular cancers. and as you can see, it was mainly confirmed by pathology. It was just one IG4 cholangitis in the pathology and not the cholangiocarcinoma as expected. The laboratory tests on POD5, the baseline tests, you see the mean bilirubin was around 100. It's just important to look at the units here. And the INR 1.9, and we had no major problems with ongoing infection. We had no very low platelet counts as well, and just one patient, but this was a special patient because he has multi-organ failure due to a multi-organ resection, and we probably wouldn't have included him, but he fulfilled the criteria and it was possible to treat him, so therefore I show his data as well. All of the patients had complications prior to the MARS treatment, whether related to the surgery, to the liver resection, or to the ongoing liver failure. 4 of the patients had hepatic encephalopathy. We had sepsis, we had ascites, we had bile leakage, but we could handle it in a way that the patient anyhow could start treatment between POD 5 and 7 and fulfilled between 5 and 7 treatments. However, again, due to resource problems at the ICU, we had to interrupt 2 patients, or the treatment for 2 patients, and split it up 2 times, but fulfilled the treatment protocol anyway. If we have a look to the outcome, well, if you just very briefly, bilirubin was reduced by about 30%, so MARS did what we have expected. We had a detoxification effect. INR was or remained almost unchanged, but I have to say this is the one patient with the multi-organ failure, so if we would remove him, it would look like a little bit different. As you can see, the 90-day mortality was just this one patient. All the other patients survived 90 days. And therefore, I'd like to conclude with the most important clinical observations and conclusions. And as we could see, MARS is feasible and safe in the post-hepatectomy liver situation. We had in our hands no complications related to the treatment. The most immediate effect could be seen when we treated the patients with hepatic encephalopathy, where we could actually avoid mechanical ventilation, and the patient improved within just 2 or 3 days dramatically. 2 patients anyway developed something we call now chronic or acute liver failure. This means the patient were improving initially, but then deteriorating again after 2 to 3 months, and both patients died after 4 to 5 months in the picture of a chronic liver failure. And as I showed you, low 90-day mortality, which is of course not statistically significant, and I'd be very cautious with the interpretation of this data, but the mortality is anyway lower than we should expect according to the inclusion criteria by the 50-50 criteria. Thank you for your attention.
Thank you.